Hello, Professor Strauss.
Hello.
Thank you for being here with us today.
It's my pleasure.
Okay, I just want to ask you to briefly introduce to me your paper, what you will be discussing tomorrow. Just a bit, and then we'll go on with our questions.
Okay. Well, the paper tomorrow is going to be trying to get back to some of the things that we were talking about the basic nature of psychiatric problems and how we learn more about them in terms of get information. And specifically, I'm very interested in traditional scientific procedures and proof and statistics and data and so forth. But there's another part to psychiatric problems, which is the part that you were talking about, which is the human part.
Yeah.
That's human in the sense of more complex human feelings and emotions and experiences. And so tomorrow I want to talk about those and about how we can pay more attention to them, take them more seriously, and also how we can become aware of what those emotions are. And part of that, and I'll be talking about this as well, part of that is that humans are not just passive recipients of experience, but humans act, they make decisions, they choose, they decide what they want to do, and that makes the scientific problem very difficult to study, especially when you think about people's subtle feelings and so forth. So the question is, how do you deal with that aspect of a human being when you're trying to be scientific?
Okay. One of the things I wanted to ask you, we shared thoughts in our emails before coming here, is the point of understanding the patient's experiences. What I really want to understand from you is what you mean by understanding patient's experiences. What's the point of understanding these experiences in terms of curing patients?
Well, the patient's experience sets up the definition of disease or disorder. That what in the past often we've talked about hearing voices, hallucinations, or delusions, having unusual, bizarre ideas. And those were considered to be the main kinds of experiences that patients have that identify that they have a problem and that they have maybe a particular diagnosis. My point is that even those experiences are much more complex than just hearing voices. If for instance, you listen to an audio tape that has voices that would be like hearing voices, you notice, as I've experienced, and a lot of people have now, that hearing voices is not just the voices, but you can't pay attention to other things, that it can be very upsetting, so that there's a much more complicated set of experiences than just the voices themselves.
Okay, so when you understand these experiences, I mean, possibly when talking to the patient during the psychotherapy, what's the point? Is it just to have patients sort of deal with these voices of these experiences? Or it's just so, cope with them? Or is it aimed at helping these people get rid of these voices and, get better in a way?
It has several levels. One, again, we're talking about the experience is the basic data. It's the scientific data as well. So that if you're going to study it, if you're going to do research on it, you have to know that it's not just the voices, but it's a whole group of things. When you're working with somebody, if you think that that the voices are sort of isolated and that's all that's going on, you really don't understand what's going on with that person. And it makes it very hard then to help the person, because you're working with one thing and their life and their experiences are something different. For example, if you are just paying attention to their voices and you don't notice that hearing voices for them makes it impossible for them to talk with somebody, that you're not really knowing what they're experiencing, and it makes it harder to help them. After I heard these voices tapes, and I was, I'd known a lot of people, worked with a lot of people who heard voices, but after I'd heard the tapes, and there's one person that when I came back to my practice, and to the research, that my attitude had changed towards voices. When he told me that he heard voices and was trying to go back to college, I was much more sympathetic than I had been before, because I had at least some sense that hearing voices and trying to do college work was so difficult, and that here he had the courage to do that. So the idea that I now understood him more, his courage meant that we were connecting in a different way.
Okay, so it's your being sympathetic, understanding what's going on in his mind, on the patient's mind, builds up a sort of relationship with the patient that helps the patients?
I think so. In that case, it was doing research. So,
Okay.
but he said, it's not a scientific kind of thing, but he said that it was really helpful to have somebody understand what he was experiencing, and maybe for the first time.
Another thing that really struck me when reading your emails was that focusing too much attention on the biological, organic causes of the disease sort of made psychiatrists or American psychiatrists incomplete scientists. This is really interesting. Can you just explain what you mean by incomplete scientists?
Well, what I meant was that, again, that the human experience is much more complex, for example, than hearing voices. And that if you're only paying attention to the voices, which has often been the case in the past, then you're only looking at some of the data. You're not looking at all the data. And if you're not looking at all the data, you may be not doing very good science.
Okay.
So that's...
Okay. We've been discussing before about how the American psychiatrist stands now. Just want to get a picture in terms of what some authors think, that American psychiatrists have been marginalized and replaced by drugs to contain and by social systems to support patients. What are your thoughts on this?
Well, I have to defend American psychiatrists to start with. That I think that there's a diversity of psychiatrists in the United States, and then when we talk about American, well, how does that differ from, say, France or Italy or some other place? So in each country, there's the diversity of what people do. The tendency here has been there's been more emphasis on medications for a variety of reasons, but one of the reasons is that if you had a medication that really worked, it would be much more efficient and quicker and easier than, say, prolonged psychotherapy or psychoanalysis, or changing the social context in which a person lived. So I think there was, at least partly, there were a lot of economic and political factors involved as well. But one of the things was that it would be easier.
We were discussing about the difference between disorder and illness. And you said that speaking of schizophrenia, for example, as an illness, implies the need to give a sort of organic treatment, maybe drugs, leaving out all the other issues. Is that what you tried to explain?
I think that's true. I don't have a dictionary with me, but I think in general people use the word illness to, like pneumococcal pneumonia or a thyroid disease or something like that. And it's used mostly in an organic way. I think, and I think it has implications for treatment and research and so forth. I think disorder is a much more general word, and it doesn't say, well, we know what's causing this, and we don't have to pay attention, for instance, to social factors or stigma or things like that.
Well, my point was that if you don't speak of illness or mental illness, you cannot really speak of a cure.
My feeling is that we don't know for sure. If there is a cure, then I don't think we've shown it scientifically for the different mental illnesses. There are certainly a lot of things that help people get better. One of them is medication, sometimes or frequently. Another one is sometimes psychotherapy. Very often it's like helping a person work, have a job, or find a place where they feel good about themselves in the community, and that in that case their symptoms may get better. So it varies. As I say, I think that's one of the themes that I really try to pursue, is that I think with most psychiatric problems, we're talking about complicated problems, and there's the term biopsychosocial. And I think that we're talking about that kind of thing, where each of these areas makes a difference.
So are you saying that we cannot really speak of cure and curability in a mental illness? Are there some, I don't know, disorders, as you say, or illnesses that can be cured somehow?
Well, there probably are some, and there are ones, for instance, with organic causes. So there are some sort of psychiatric problems, for instance, that have too much thyroid problem, and that can be cured by curing the thyroid problem. But the question becomes then, how about something like schizophrenia or certain kinds of depression? And I'm not sure that the usual medical sense of cure holds for these kinds of problems.
So what's the role of psychiatrists?
If there's no cure, well, a lot of medicine does not involve a cure. Cure means that that the problem goes away entirely. A lot of surgery is just to help repair or to make things better, and a lot of treatment for cardiac problems or for other problems is to help it function, help the heart function better, without curing, without actually getting rid of the disorder or the disease. And a lot of what goes on in psychiatry is that you help people function better, or maybe the voices become less severe, or person is able to work, or they're starting to relate better to other people, and sometimes the symptoms go away too. So your idea of cure is interesting, but it's not the only thing that medicine does.
Okay, I see the point. Another thing we were discussing before was the medical identity of psychiatrists. So what is the medical identity of a psychiatrist based on then?
That's a very good question. I was talking with two colleagues about that last night, actually, including Dr. Davidson, whom you'll see tomorrow or Saturday. I think one is certainly that to some extent medications can be helpful, and sometimes there are clear biological causes of psychiatric problems. And in that sense, the physician is probably better educated to deal with the biological component than, say, a psychologist or a social worker. In other instances, though, there may be more a social problem or a problem with the family or something like that, in which case the psychiatrist is not necessarily better equipped than, say, a social worker. So it varies. As I was trying to explain before, I think, in my view, the whole problem of psychiatric problems or mental disorders or whatever we're going to call them is at a meeting place between the biological, the psychological, and the social. So the more there's a biological component, the more the physician is probably better.
Yes, but tell me, just for you, when you talk about medical identity for you, for a psychiatrist, from your point of view, what is based on for you?
Oh, for me personally,
Yeah.
I like having the medical background for two reasons. One is because you're more sensitive then to possible biological causes. As I was saying, some of the psychiatric pictures are from too much thyroid hormone. The other aspect, which is really quite different from that, is that physicians often have the experience of having to work with, first of all, very ill people, and people where the physician has to take responsibility for the treatment decisions and so forth. And that in certain instances in psychiatry with patients who are terribly disturbed and maybe violent, the physician, again, the doctor has to take charge of what happens to that person. Are they going to be put in the hospital whether they want to be or not, for example? and that a physician has more experience than a lot of other people with places where he or she has to take over the responsibility.
Okay. We were also discussing about the DSM, and my point was that by introducing the word reaction, first schizophrenic reaction and then disorder, the DSM voided of sense the term mental disease. So again, you tried to explain me that there was the need to sort of help all the physicians all around the world to identify symptoms to make a diagnosis.
That's a different thing. There are two questions here. One is the thing that you talk about diseases or disorders. The way that the earlier diagnostic manuals talked about disorder was the idea was that they were often caused, the problems were often caused by social or experience and other factors. Then when it went to diseases, the schizophrenia as a disease, the idea became more biological. The other issue, and that's this thing we've been talking about between biological, psychological, and social cause. The other thing is clarity, is to reach some way of categorizing a person from a medical background, to use a diagnosis. And that's a very important, very valuable thing. Whether it's equally valuable for psychiatric problems is still somewhat of a question. But when a person says, well, I have a patient with depression, so depression is a diagnosis, I have an idea what that patient has or what some of the problems is. I don't know specifically, but I have an idea. Or if a person says, I have a patient with schizophrenia, again, I have a somewhat of an idea of what that person's problem is. So diagnoses are very important. But they're not, it's the diagnosis in psychiatry mostly is not as specific as somebody saying, well, I have a patient with pneumococcal pneumonia. Because there I know that it's a certain kind of disease.
But I thought that DSM was not only focusing on diagnosis, but on obliging us, if I can say this, physicians to prescribe drugs, rather than focusing on on the mental reality of patients.
Yeah, no, as I tried to explain before, that the connection between treatment and diagnosis, there's not a necessary connection there. Diagnosis is trying to say what this problem is. Mm-hmm. The question is how the problem should be treated is a separate problem. And the one does not imply the other. There has been a tendency, though, to say when we have a clear diagnosis that it may be for a medication treatment, but that is not necessarily the case at all.
I thought that, there was a sort of failure, if I can say this, because of focusing too much attention, money on drugs. I mean, I told you that I read on the papers that the American president and also the first lady, they just talking so much about mental illnesses, mental issues. They're inviting people not to feel guilty about these problems and to try and get help. And also, I've seen that there's so many helplines available for people to get into contact with. And I say, okay, is it the result of a failure in doing research in another way, of focusing, on the people, on what you said, the human psychiatrist? Is this a sort of failure? That's why all these things are happening, or what's going on? I mean, I cannot really see the point. I cannot really understand.
Again, I think you're mixing several things. One is the national picture, and there it's hard to compare. We, in the international study of schizophrenia, we actually it was a 9-country study of schizophrenia in different countries. And what happens is that there are many different factors that operate. So one thing with the president, I didn't hear that particular statement. So, but I don't think that's necessarily connected to drugs at all.
Okay.
That's connected more to the concern with suicidal behaviors or psychiatric problems. the question is, is there more concern in the United States than, say, Italy or France? That I can't say, but I do know from other experiences I've had internationally that in some cultures people don't talk about suicide, so that it's not that there's no suicide there, but that nobody talks about it. And I think one of the things that's going on in the United States now is that they're trying to get more. Make it less stigmatized, so that it's not a horrible or an evil thing to feel depressed or suicidal. So to reduce stigma, and so to make people come out more easily and say, I have this problem.
Can you just tell me, if this is possible, which is the best psychotherapy approach to treat mental illnesses or disorders? Is there one which...
I think there's a tremendous amount of individual variation. That some people respond, let's say with people with a diagnosis of schizophrenia, respond well to certain medications. Some other people respond well to other medications.
Is it the same for psychotherapists?
With the same disorder, with the same diagnosis. In almost all instances, in my view, people need some kind of psychological and social help as well, because again, there's the problem of stigma. There's the problem of a person with schizophrenia often has been isolated from the community, and they need help getting back into working or a living setting, so that often with the severe psychiatric disorders, there are many different kinds of related problems, and it's very much individual related. So to say, well, what is the best kind of treatment? It's not like penicillin and pneumococcal pneumonia.
I know this, but just whether it is more CBT or whether it is more, the psychodynamic psychotherapy,
There are a lot of studies being done on exactly what are the best treatments. And there are comparisons. The studies are difficult to compare very often because they may be working with people with different levels of severity. So, for instance, there can be a person with schizophrenia who's able to live and live well and do well, and where you wouldn't know that this person has schizophrenia. And there are other people with schizophrenia who are so disabled that they have to be in a hospital. So to compare different treatments, this is again where the science comes in. To compare different treatments, you need to be sure that you're talking about the same people with the same level of illness.
So what do you do? I mean, when a patient comes to you, just talk to him and try and see what is best for him.
Absolutely. That it's very individualized, and you can people, for instance, maybe they've been taking a particular medicine, and it hasn't been that helpful, and you say, well, let's try another medicine, see if that's more helpful, or I notice you're on medicine, but you don't have anything to do during the day. And maybe we can get you into some sort of a work program where you can be working and you're not just thinking about your illness. So yes, absolutely, it's very individualized.
It is social. It is some drugs if drugs are needed, and it is the best psychotherapeutic approach that that patient can get from a psychiatrist.
Yes, yeah.
I've read in one of your emails that music, theater, art, I was just thinking to ask you about, the issue of creativity for these people.
Well, I think there's a lot of literature. I mean, it's known that a lot of people with severe psychiatric problems have also been very creative, and in literature and music and other things. So that's for sure. Whether it's more than the normal population or not, I don't know. But creativity can be a part of helping a person with psychiatric problems express themselves or express their feelings in a more effective way than they had been able to before.
Okay, I've read somewhere, as I said, I'm not a psychiatrist, that for mentally ill patients, I mean, they are creative, but in a different way. I mean, their creativity is nothing universal. Real creativity, for painters is universal. It is a universal language that everybody can understand. What do you think this?
Oh, I don't think there's a universal explanation. I've certainly known psychiatric patients, partly, I think, perhaps because they were not thinking in the usual way, who could paint in a very unusual way and very beautiful way. So that there's sometimes that people have had psychiatric problems who are able to see the world in a somewhat different way from other people, and that other people can still relate to it.
Okay. It just said that possibly we just need to use a different word, but not creativity for patients, for mentally ill patients. It is not creativity. It is something else. It is originality.
Yeah, no, I think there are some psychiatric problems where it's disorganized thinking or unusual putting together words in ways that don't make much sense, that I don't think I would call that creativity, but sometimes sort of unhooking a little bit from everyday reality can allow a person to be more creative in what you're calling a universal sense. That there are a lot of people around on the street who are they're going through their lives, but they're not being very creative. And they're sometimes if a person has psychiatric disorder, it does allow them to see things in different ways. That is also universal. I've seen that, for instance, in group therapies, that sometimes a person, a therapy group with maybe 10 people in it, and it may be that the psychotic person is the one that notices that there's something unusual going on in the group that nobody else has noticed, but then it's true. Once the psychotic person says, well, the group we're all very angry at each other or something like that, that the other people in the group notice that, yes, in fact, that's true, but nobody else noticed.
Okay. In your sort of psychotherapy with your patients, does the non-conscious mind have a role?
We're sort of coming out, at least in many places, of a psychoanalytic Freudian kind of way of looking at the unconscious mind. So that I think there are some changes in people questioning that or how important that is. But in my view, yeah, there is something going on in all of our unconscious that we're not, in our minds, that we're not aware of, or not clearly, or that we're afraid of something, or that we've had an experience in the past that have gotten into our mind that we can't recall. Yeah, and I think that's true with people with psychiatric problems or with people who don't have psychiatric problems.
I'll try with the last question. I don't know what the answer may be, but we talked about the non-conscious.
That's in English. That's called unconscious, I think, or subconscious. But anyway.
Well, yes.
Okay.
But there is, maybe there is something different by saying unconscious and non-conscious.
Okay,
because unconscious seems to imply that it cannot be known. Non-conscious maybe implies that thought, that thinking may be somehow known. I just wanted to ask you something about dream interpretation.
Ooh, yeah.
Whether it plays a role, and if it does, what it is.
I think that depends very much on the professional person. That of course, as you know, I mean, dream interpretation goes way back to biblical times, if not before. That.
Homer.
Yeah, that I think that my personal opinion is that dreams can, I mean, from my own experience too, that dreams can bring up things that you've worried about that you have not noticed yourself, or things that you wanted to happen, or things that you're afraid of. So, and I think, personally, I think that's true, and I think that's true with the person with psychiatric problems or a person without major psychiatric problems. Dreams are a way, I think, dreams are a way of not always, but partly a way of ideas coming out, which I think you were calling non-conscious, but in English would be more likely to say unconscious, ways of coming out that can be helpful for people to know, sure.
Okay.
I think.
Okay.
Okay,
Thank you.
sure.
Thank you.